Good afternoon, everyone. This is Emily Clark. I'm a knowledge broker for the NCCMT, and I will be your host for today's peer-to-peer webinar brought to you by the National Collaborating Center for Methods and Tools. Thanks to those of you who have joined us for today's webinar. Just before we get started, we'll review a few housekeeping items. Please take a look at the chat section, which should be in the bottom right-hand side of your screen in WebEx. You can use this chat section to post any questions or comments you might have during the webinar. We will have a designated Q&A session at the end of each presentation, as well as an open one at the end of the webinar, but please feel free to post any questions or comments you have during the webinar. When you post in the chat section, please make sure that you post your comments to all participants, as other participants may have the same questions that you have. And today we do recommend using a wired internet connection as opposed to wireless, if possible. And Vivian Chen is on the line as well. So if you are having any technical difficulties, please send a message to her and she should be able to help you sort that out. After today, the presentation slides will be available in both English and French, as well as a video recording in English posted to the NCCMT website. The link to this page is posted in the chat section for you. And we'll start with our first of a few poll questions today. We're just hoping to get a sense of the audience that's joining us today. We're wondering how many people are watching today's session with you. So please indicate if it's just yourself, if there are one to three people joining you, 4 to 6 joining, or 6 to 10, or if you are in a larger group. You can answer this question in the poll question panel on the side of WebEx, and just make sure that you hit submit so that your answer gets recorded. And it looks like we have a couple of smaller groups, 1 to 3 and 4 to 5, as well as a number of people joining on their own. So thank you so much to everybody who has joined us. I would like to officially welcome everybody to the third and final for this year webinar for the peer-to-peer webinar series. This was a webinar series that we designed to share success stories in evidence use in public health across Canada, and to help demonstrate that evidence-informed decision-making is achievable and realistic in various settings. For those of you who may be unfamiliar with the National Collaborating Center for Methods and Tools, we're actually one of 6 national collaborating centers across Canada. We're all funded by the Public Health Agency of Canada. We here at the NCCMT are located at McMaster University in Hamilton. As you can see on this slide, the other NCCs focus on specific topic areas in public health, whereas here we're not topic specific, and we focus on improving the access to and use of methods and tools for health professionals in practice across Canada. We offer many products and services through our website, a few of which are highlighted on the screen here. The Registry of Methods and Tools is a database of resources that support knowledge translation in public health. Some of our online learning opportunities include our online learning modules, a core competency tool that links resources from the NCCMT to the core competencies for public health, a rapid review guidebook that details all the steps of conducting a rapid review, as well as a skills assessment tool that can help you identify gaps in your knowledge and skills for using EIDM. Public Health Plus is a collection of quality appraised studies and reviews relevant to public health. So those have been all being curated through McMaster. And one of our video series that's most popular is the Understanding Research Evidence series, which explains statistical concepts in easy to understand 5 to 10 minute videos. And finally, another thing that we engage in is a lot of networking and outreach to help promote evidence use across the country. Today's webinar will highlight some of the very interesting stories that are featured in our evidence-informed decision-making casebook. The casebook was launched earlier this year online. It is available on the NCCMT's website. And this is a collection of success stories. And there are a total of 9 in the casebook that you can check out. So there's success stories of evidence use in public health in a number of different settings and contexts, and we'll hear from 2 of those stories today. So I'm very pleased to introduce our first set of presenters. We have Becky, John, and Amy from the Simcoe Muskoka District Health Unit. We were very interested in having the Simcoe Muskoka District Health Unit present their story because what they did was a rapid review. And rapid reviews have been emerging as a very popular method for health units and organizations to quickly and rigorously synthesize evidence. So thank you so much for joining us today, and I will pass it over to you.
Okay, thank you so much, Emily. So hello, everyone, and thank you to Health Evidence and the NCCMT and everyone else on the webinar today for your interest in our rapid review. I'm Becky Blair, and I'm a dietitian nutritionist in a child health program here at the Simcoe Muskoka District Health Unit. I was the staff lead for our internal EIDM group and was also the lead for our rapid review process. Members of our EIDM team, John Barbero, one of our epidemiologists, and Amy Faulkner, our librarian, as well as our child health program team manager, Natalie Levy, will be presenting today. Brenda Guarda, our population health assessment and surveillance and evaluation program manager, is also in attendance. And now she was the manager for our whole EIDM work for our whole agency. And so if you have any questions about how our EIDM work overall is proceeding in our agency, please feel free to ask her. I would also like to acknowledge the great work of our EIDM team who can be with us today, Louisa Zara, Sherry Diaz, and Tanya Fair. So for today's presentation, I will describe our research question selection process. Amy will talk about how we developed our people question and our search strategy, and she will also talk about how we selected the studies to include in our rapid review, as well as the quality assessment process we used. John will describe the characteristics of our included studies, and we'll talk about the additional analysis he conducted that was included in our rapid review, and I will provide an overview of our main findings. Finally, Natalie, our program manager, will talk about the process we went through to determine applicability and transferability of our findings and how the Child Health Program applied and shared our rapid review results. For anyone who's interested in reading our full report, please go to our website and the link to our report will be posted right here in this webinar chat room. So, to select our rapid review questions, we first asked each of our 6 service areas, which are now departments, in our agency to provide at least 3 to 5 questions they had that was needed to support public health program planning. 12 questions were received overall. Each question was scored against 7 predetermined criteria and were then ranked. The criteria we used were, 1, the information was needed to inform a major decision. It had to be timely, that a decision was required between 6 to 8 months in time. The amount of the available evidence had to be adequate. The rapid review results, a question had to be amenable to completion in about 6 months, so the topic couldn't be too broad. And the service area had to provide some sort of consultation to the EIDM team to support the content piece. And our question also had to have an agency impact and had to align with our strategic direction. So 2 rapid review questions ended up with the highest score. Our rapid review question ended up being chosen because one of our local health networks, what we call LINs, received funding to assess and improve local perinatal mood disorder services in Simcoe County and the District of Muskoka. Therefore, this rapid review was chosen to help us understand what our role could be to implement prevention programming in our communities, as well as to inform overall local service planning across our region.
Thanks, Becky. There are many different models or frameworks which can help you structure research questions. PICO is one type of framework, and it fits for our question. Using a framework can help you identify the key concepts in your question. This step also helps when you're developing a search strategy and deciding on your inclusion and exclusion criteria. So for our question, our population was pregnant or postpartum women at no known risk or at risk of developing perinatal depression or an anxiety disorder. We define perinatal as the time starting at conception to up to 1 year postpartum. Our intervention consisted of any psychological or psychosocial interventions. Psychosocial interventions were defined as interventions that take place in the social environment. so those that enhance supportive interactions or create supportive relationships. Psychological interventions were defined as those interventions that are based in psychological methods, such as cognitive behavior therapy, interpersonal psychotherapy, or psychological debriefing. In our case, our comparison was standard or usual care, and our primary outcome of interest was the proportion of women diagnosed with perinatal depression or an anxiety disorder. The outcome of a diagnosed perinatal mood disorder was as defined by the authors of the included study. And the term diagnosed was defined in 3 possible ways: by using a specific cutoff value on a scale as defined by the author or authors to classify perinatal depression or an anxiety disorder, by the author referring to a probable diagnosis or as a depressive or anxiety disorder episode. One of our inclusion criteria was that the original trials could contain no more than 20% of women with a current mental health diagnosis at baseline. Outcome measures for diagnosis of a perinatal mood disorder had to report an odds ratio or relative risk reduction. And given our outcome measure of diagnosis of depression or anxiety post-intervention, studies reporting outcomes related to decreasing symptomology of perinatal depression or anxiety were also excluded. Another inclusion criteria was that the trials were conducted in high-income countries. The definitions document was developed while the search strategy was being finalized to ensure any concepts we were interested in were being searched for in the literature. As well, by having a set list of definitions, we weren't searching for topics that we weren't covering in our review, for example, other types of mood disorders. When we were screening studies, it was also vital to the group because we had one document all members of the team could refer back to. The databases were searched in January of 2016. We limited the publication years of the articles to be between 2013 and 16. We chose the 2013 date to find articles that may have been published after the Cochrane Review by Dennis and Dodwell, Psychosocial and Psychological Interventions for Preventing Postpartum Depression, had been published.
Sorry, I'm getting a message that people are hearing feedback on the line. Is that the case for everyone listening in? I just had a couple private messages saying that they're having trouble hearing us.
Interruption.
Yeah, no problem. Amy's just going to pick up on the search strategy slide.
Okay, so I'll just go through the last little bit. So the databases were searched in January 2016, and we limited the publication years of the articles to be between 2013 and 16. We chose the 2013 date to find articles that might have been published after the Cochrane Review by Dennis and Dodwell, Psychosocial and Psychological Interventions for Preventing Postpartum Depression, had been published. In addition, because this was a rapid review, this was one way to make the process more rapid because there were less references to review. The initial Medline search strategy was peer-reviewed by 2 additional librarians. This is beneficial because it allows a second set of eyes to ensure that no concepts are missing from the search strategy, there aren't any spelling errors, and all of the different concepts are combined correctly. No one wants to find a mistake in the search strategy after the team has begun reviewing the results or have started writing the paper. I structured the search to try to limit to randomized controlled trials, systematic reviews, meta-analyses, or guidelines. We also limited to English language articles. Documenting the search strategies allows for greater transparency. In our review, we attached the Medline search strategy as an appendix. This is also beneficial because if someone else is thinking of doing a review on a similar topic, they can check to see exactly what concepts were searched for. Search strategies can also be of varying quality and can be one way you can assess the quality of a paper you are reviewing. Documenting the decision-making process is important as well. Sometimes not all team members could be at meetings or be involved in discussions, so documenting everything is key to ensure everyone is on the same page. Authors of Cochrane Reviews located in our initial search were also contacted. As well, ensure that you have enough time to discuss iterations of the search with key members of the team and subject experts. So for study selection and quality assessment, at least 2 team members screened the initial list of titles and abstracts and then reviewed full-text articles for inclusion-exclusion as required. Disagreements were brought to the entire group for consensus. Full text articles went on to the quality assessment stage. Only systematic reviews and guidelines were considered for quality assessment and inclusion in the rapid review results. All systematic reviews and meta-analyses were assessed using the AmStar quality assessment tool, and the 2 guidelines were appraised using the Agreed-to tool. This process definitely did take some time, even with 6 team members breaking the work down into manageable numbers. And although it did take time, it ended up being manageable. Sometimes the title and abstract would not have enough information to tell us what type of study it was or if the content was relevant to the PICO model, so you would have to pull up the full text. We made sure that if we were unsure that the article went on to full text review. It is also critical to make sure that the intervention and the population of interest is clearly defined prior to searching. One example for us was deciding what list to refer to when deciding if a country would be classified as a high-income country for inclusion. We used the list from the World Bank. Utilizing the assessment tools helped us to exclude reviews that would have been utilized as good research when they were not, and allowed for us to be completely transparent about our assessments. After the databases were searched, I removed the duplicates using EndNote, which led to 1,701 results. If it is your first time looking at references retrieved from a search conducted for a rapid review or systematic review, the number can appear daunting. One thing to keep in mind is you will not be reading 1,701 full-text articles. There are varying amounts of time it can take to conduct title and abstract screening. The Cochrane Handbook suggests a conservative amount would be about 120 in an hour. If you look at this time in comparison to the amount of time spent reading full-text articles, critically appraising the articles, and writing up the report, it helps put the time into perspective. After removing primary studies, there were 15 articles which went on to quality assessment. In the end, we included 2 guidelines and 4 systematic reviews, which John will now discuss in more detail.
Okay, thanks, Amy. Here you see the table of the main characteristics of the reviews that were included in our paper. I won't, there's a lot of detail here. You can look at our rapid review to look at it in more detail. I just wanted to highlight a few things. One is that for each of the reviews that met our inclusion criteria, we listed the number of studies that reported our outcome of interest, which is diagnosed mood disorder, not a change in symptomology, as was mentioned earlier. That's the second column. So, for example, in the Dennison-Dowswell paper, it included 5 studies of interest out of their 28 studies in that Cochrane review. And the combined analysis for those 5 main studies did show a significant combined relative risk of 0.5 or a 50% risk reduction. However, in a couple of slides, I will show you a reanalysis that we did of those 5 studies using intention to treat, or ITT, which showed a non-significant result after making that adjustment. For the Pilkington study, there was only, or the Pilkington paper, there was only 1 study of interest that was included, and that showed a non-significant result for the outcome. There were also 2 Stockel reviews that made our inclusion criteria, and both did show a positive result for the outcomes, but due to different methodological issues in terms of the overall quality, which I think maybe Becky will speak to later, did not impact much on our findings. There were also 2 guidelines that met our inclusion criteria. The highest quality one was the NICE guideline, which received a 7 out of 7 score from using the Agree tool, and the BC Reproductive Mental Health and Perinatal Services guideline, which was of lower, assessed at lower quality, a 4 out of 7. To note, neither of the reviews provided any recommendations specific to the prevention or interventions for the prevention of depression or anxiety in the antenatal or perinatal period. However, there was some available evidence for the prevention of depression within high-risk populations, which was not our specific population of interest in our PICO. The next two slides are forest plots. So this is the original data from that Dennis and Dowswell paper with those 5 studies showing that 0.5 relative risk or 50% risk reduction using the available case data, which was the analysis that was done in the Cochrane. However, using some of the appendices that were available in the NICE guidelines, we were able to obtain the data for the intention to treat for those 5 studies. And this forest plot shows same 5 studies, but after making the adjustment for the intention to treat, the relative risk went from a 0.5 to a 0.86 with confidence intervals overlapping 1, which is no longer significant.
Okay, this is Becky again. And so just to go over our main key findings. So the first point we really wanted to highlight was overall for this topic, the evidence base is really small for this whole area of prevention of perinatal mood disorders when we're looking at the outcome of preventing a diagnosis. So you could probably say it's almost sparse. And for whatever studies we do find, or the 5 studies or whichever, we did find a few studies, they were of low methodological quality. So overall, the evidence base is pretty sparse. So right off the top, we kind of know we can't do much with this evidence base overall moving forward. Another point we wanted to highlight was different authors used different definitions for what they considered prevention or treatment in their studies. There was also different definitions used for what was considered a psychological intervention or a psychosocial intervention. And sometimes activities or trials categorized as a psychoeducational intervention were categorized as a psychosocial intervention in other papers. So there was a wide variety of definitions. There was also a wide variety of outcome measurements, and different depression scales were used across different studies, and different thresholds were used within different studies for individual scales, which made comparing overall results across multiple studies difficult. Overall, as John had said before, none of the guidelines we found, any of the 2 guidelines, did not recommend the implementation of psychological or psychosocial interventions for the prevention of perinatal mood disorders. The NICE guideline, which John also noted, was the strongest piece of evidence that we found. It implies or says there's no strong evidence that psychosocial or psychological interventions are effective to prevent the diagnosis of a perinatal mood disorder in women, and particularly that's women at risk. We don't really know at all, according to the evidence, what can be done for women without risk. The Dennis Cochrane review found a large 50% reduction or beneficial effect of combined psychosocial and psychological interventions to prevent the diagnosis of postpartum depression compared to routine care. However, again, as John noted, this finding was based on 5 studies, and most of those were low quality. And as he described in his forest plot, doing different analysis and taking out studies that were considered high risk of bias, there was actually no significant difference between intervention and control groups. So one of the lessons learned, and maybe a key lesson learned as we went through this rapid review process, is it's really easy to accept the conclusions of a systematic review, especially if they're authored by an expert in the field. And we just wanted to note that critical appraisal is still really important, and you really need to look at the data presented. And an example of that for us was at the end of our rapid review analysis, before we started writing, we had really 2 conflicting reports between the Dennis and Dowswell Cochrane review and the NICE guidelines, one finding a 50% reduction and one finding no significant difference whatsoever. We really had to dive into the data pieces for both of those 2 guidelines to understand the differences, and it turned out there were multiple differences. And because John was able to do the reanalysis of the forest plot of those 5 studies in the Dennis Cochrane review, we were able to make a decision around which piece of evidence to go with. Another comment I just wanted to share with the group is that one of the Cochrane reviews that we ended up excluding for rapid review was a Cochrane review from Yamamoto et al. In 2013. And one of their analysis 2.9, suggested that there was actually some harm related to home visiting, flexible home visiting programs on the outcome of a diagnosis of depression. And in that particular analysis, they only cited one particular paper, but when you actually looked at the paper, it reported conflicting results to what the forest plot result in the Cochrane Review reported. And so in discussions with Natalie and then just asking John to explain why this was the case, John was able to figure out that there was imputing error in the analysis in the Cochrane Review. So we subsequently emailed the author who acknowledged, yes, there was an error in the Cochrane Review, which has since been corrected in the recently re-released Cochrane Review just in 2017 on home visiting, the benefits home visiting programs. So that's a pretty interesting result. And so, Natalie.
Right. So after the findings and sort of the finalization of our rapid review report by the EIDM team and its review and approval by the lead program managers, we needed to find a tool in order to share and process the results for the internal programs at the health unit who were involved in providing supportive services for families experiencing perinatal mood disorders. And so we were using the applicability and transferability tool to discuss the findings with these groups to determine what the impact of these findings would be for program decision-making internally and for sharing the knowledge externally. And so we went through an applicability and transferability process and facilitated by Donna from the National Collaborating Center for Methods and Tools. And so one of the first steps to the process of applicability and transferability was to determine what our actionable message was related to the findings of the rapid review. And so as a group that involved managers from the Reproductive Health, Child Health, and Healthy Babies and Healthy Children's Program and our Associate Medical Officer of Health, we determined that the actionable message would be that there was no evidence to support a change in practice with respect to public health's role in preventing the diagnosis of perinatal mood disorders. And for our programs that provided services for these families, we were not looking for this type of finding. We were hoping to find a finding that would provide clear direction on an intervention to use within our programs to help prevent perinatal mood disorders. So because we weren't able to find a clear program that we could begin using in our programs, we had to sort of determine then how we would transfer this message out externally to other public health units who are also looking at the public health units' roles in perinatal mood disorder work. And so part of that process involved sharing the key message within our local community partner tables and also provincially with other public health units at manager meetings and with other agencies like Public Health Ontario who are also looking into this issue.
Okay, thank you, Natalie. Are there any questions?
Awesome. Thank you so much for the overview of your rapid review. I really like that you highlighted the lessons learned for everybody and actually included the piece on applicability and transferability. I think that's really relevant to a lot of people. So we do have a few minutes for questions now. So we will wait a few minutes for questions to come in. In the meantime, I'm curious, what were the reactions like when you finished your rapid review and the final message in the end was not to do anything, not to change anything? You know what I mean? It seems kind of, what were the reactions like to that?
I think especially for our internal staff and our external partners, we were sort of, again, we used the rapid review to determine next steps for programming, and what we realized is the programming that we were already doing was probably continues to be the appropriate role. So we provide supportive services to women who are with risk or at risk in terms of perinatal mood disorder, and we do that through increasing awareness for prenatal families in terms of what perinatal mood disorders are and what they can look for in terms of their own health and talking to their healthcare providers. And then in terms of our Healthy Babies, Healthy Children's program and their home visiting with women who do experience perinatal mood disorders, and as well as when we encounter families in the programs and services in terms of continuing to provide the supportive services and link them up with treatment programs within our community. It also helped us move within our local community to really focus on trying to improve the treatment services available in our community. And so a coordinator that, again, has been hired to the LHIN has been working across our LHIN to help increase perinatal mood disorder treatment programs through the different healthcare provider organizations we have. So that's so those are sort of the next steps. So realizing that we were still doing good work and that we didn't have to try to move into a new program. What we were doing is still sufficient for public health's role, and that other people were recognizing their role in terms of treatment.
That's perfect. That's great. So I do have 3 questions in the chat section. We have about 5 minutes. If we don't get to all of them, we will pick them back up again during the open Q&A at the very end of the webinar, but I don't want to cut into the next presenter's time as well. So the first question that came in was, would the findings have been different if your PICO question O, outcome, had been perinatal mood disorder symptoms versus a diagnosis, keeping in mind that many women do not seek medical attention?
Hi, this is Becky. That's a great question. And in fact, in our report, we did address this particular question just to say that we went back to the NICE guideline and the Dennis Cochran review looking at the outcomes related to symptomology. And between the 2 high-level pieces of evidence, the information was still conflicting. And so we, although symptomology was out of scope for our particular rapid review, we do suggest in the report that there may not be much difference to the effectiveness of decreasing symptomology for the prevention of a diagnosed perinatal disorder either.
Great. And then the next question was, and I'm not sure if you'd remember this now because it's been a little while, but do you remember, is there a reason why you didn't include the clinical practice guidelines by Beyond Blue in Australia from 2011, which includes psychosocial and psychological therapies?
It was because it was outside of our search date. That was part of our rapid review criteria to make it rapid, to really make the search years very short. I think it was 2013 to 2016, right, Amy? Yeah. And so that's exactly why it was too old. It didn't meet our search date criteria.
Yeah. And I mean, that's one of the biggest difference between a rapid review and like full systematic review. The full systematic review, you've got more time. Your search period is going to be a lot longer and a lot broader. So I think that's one of the things that you do need to cut down on with the rapid review, but it's justified, and that's the way it is. So, and then the last question that we have here, and I think this was touched on with the first question, was do you think the issue was that you were looking for an outcome of diagnosed perinatal mood disorders?
And I would say absolutely, because that, I mean, and that was the focus of our question. And the reason we looked at prevention specifically and then an outcome of depression is we were trying to really focus on what a public health role would be in terms of perinatal mood disorders in regards to prevention and health promotion work. And so we were, you know, we talked about the treatment methodologies, but we didn't really see our role as a treatment service provider for perinatal mood disorders. And so we had to be really narrow, again, because of the rapid review process and because of what we were believing our role to be within this whole, you know, collaborative work related to perinatal mood disorders. So if we looked at symptomology, and again, what Becky had already shared is, you know, there's conflicting findings again with symptomology, and so we take that into consideration, which is why we describe our services as supportive services for families who are already experiencing symptomology or diagnosed perinatal mood disorders, is that we will support them in their journeys with that.
Great. Great. And then the last question that I think we have time for now is how long did the rapid review take? Would you be able to estimate the total number of hours?
We're just kind of sitting here laughing at that question. It did take a long, long time. Felt like forever sometimes. But I think it took about 6 months of solid work, would you say?
But it wasn't full time.
It was not full time. So it was kind of at the side of your desk kind of work. And it probably took 6 months overall to complete the rapid review process, and then another couple of months to write the report and finalize the report, I'd say. So total hours.
And it's hard to say because we We had our EIDM team from the health unit who was responsible for, the search strategy and the review of the articles and the findings, and then you had members of the programs who provided the content services, and talking back and forth with each other. So there was lots of hours from different people at different times, depending on the stage of the project. Yeah. But it was a 6-month project with good intensive time spent throughout that period by different people.
Great, and we do have another question. We will come back to it during the open Q&A session because I do want to stick to our schedule here because we do have another presentation as well. But I want to thank you guys for such a great presentation and highlighting the lessons learned for our audience. I think that's very, very valuable considering how popular rapid reviews, and rapid being arguable as a term, but as rapid reviews are becoming more and more popular. So I really do appreciate that. I am now very pleased to introduce our next set of our presenters. I'm happy to introduce Mary Guyton and Heidi Parker from the Sherborne Health Center site in Toronto. Mary is a treatment nurse, and Heidi was an MPH candidate who completed a practicum placement at the Sherborne Health Center site. And I will let you introduce your project. So thank you so much for joining us, and I will pass control over to you.
Hi all. So today we're going to talk about a quality improvement project to build a best practice tool to address the needs of clients with Hep C. Again, I'm Mary Guyton, and I'm really happy to be here to talk with you, and thank you for inviting us. I'm a Hep C treatment nurse at Sherborne Health Center, which is in East Toronto, and I bring a background in primary health care nursing, and I'm now part of a hepatitis C treatment team.
And I'm Heidi Parker. I'm a new registered nurse. I graduated in June from the University of Toronto with a Bachelor of Nursing, and I completed my community nursing placement at Sherborne Health Center from September to December of last year with Mary as my preceptor.
So our objectives today are to highlight a preceptor student QI project to build capacity of primary care nurses to fully support the needs of clients, and then disseminate that information from our best practice tool project as a knowledge transfer initiative. So just to give you a bit of background, a brief background of our Hep C program. And my work is through one of 3 sites of the Toronto Community Hep C program, and that's a model that houses care for Hep C within community health centers and family health teams. Our program started in about 2007 when we were discovering that clients were facing barriers to Hep C care through specialist offices because of their alcohol and substance use. And we felt that this was not right. So our program works within a harm reduction framework and wraparound care, an interprofessional team of RNs, physicians, counseling, and support staff. And our program is anchored in a group model. Heidi joined our team in the fall of 2016, like she said, for a community health practicum. So this project is really motivated by the changing landscape in Hep C care, and the newer and more effective and better tolerated treatments are increasing this Hep C treatment. We see it moving into a primary care setting. So while we are a specialized Hep C treatment program, we also wanted to understand the specific primary health care nursing sort of education needs to facilitate more comprehensive client care.
So when beginning to create an education piece for the nurses at Sherborne Health Center, I noticed that while there are best practice resources for family physicians, there was a gap in resources tailored specifically to RNs providing care to clients receiving hepatitis C treatment in Canada specifically. So while this began as a small project, we expanded the goals of the project to include exploring the educational needs of the nurses in primary care, caring for clients with hepatitis C throughout their illness as well as post-cure care, to develop a best practice resource tool as a reference for nurses. So we sought to provide basic information with links and references to more thorough resources for areas relevant to primary care RNs, including screening, treatment, post-cure care, and follow-up. We considered a variety of formats, including paper or online, as well as creating a document with our own references or links to external resources. And finally, the last objective is to disseminate this resource to primary care nursing community. And so we developed and continue to develop this tool in consultation with members of the hepatitis C team, as well as with people with lived experiences in Hep C, and the rest of the Toronto Community Hep C program that Sherburne is a part of. So, to begin the project, I started with a literature review, searching for documents for primary care registered nurses in Canada regarding care for hepatitis C. I used a PubMed database search for research within primary care nursing for hepatitis C in Canada to determine what literature, guidelines, and resources were already published. And while I found many helpful resources, they were not targeted specifically to primary care nurses in Canada. During the search, I also did a quick Google search for any potential resources that were not listed through the PubMed search, which again did not return any specific results for nurses in Canada. So through this search, it was made clear that while there are resources for nurses caring for patients with hepatitis C elsewhere, there's a gap in Canadian resources. So the PubMed search did reveal some great resources for primary care physicians in Canada and Australia, as well as I found a good resource for nurses in Australia. So after gathering the resources together, I consulted with Mary to discuss what sort of information would be important to include based on her experience with primary care nursing. And in creating the tool, I reviewed other guidelines that existed and compared them to the standards for hepatitis C treatment in Canada to ensure when we created a tool, it was relevant to Canadian nurses. So once Mary and I had reviewed the tool, we presented it to the nurses at Sherburne Health Center to gain some valuable feedback. And so during this feedback process, we provided the nurses with a paper copy of the tool at a meeting in the health center. We presented the tool and the basic components that were included and asked for verbal feedback at the time. Some of the feedback we received was including less information in the tool specifically so that the basics were easier to find. And rather than including all the information on the tool itself, include links to other sources that maintain the current information so that we did not have to continually update it, as well as to create an electronic copy of the document that would be easy to access quickly for the nurses. So after this in-person meeting, we sent out an electronic copy of the tool with the small changes that had been made after that initial meeting and asked the nurses to take a more thorough look through the tool and provide us with more feedback if they had any. And our goal throughout the project has been to use the IHI Plan, Do, Study, Act tool to ensure our project to be as effective as possible and support primary care nurses in their work and effect change where necessary.
So let's just look at our project quickly through the PDSA cycle used by IHI. So in terms of planning, we thought that nurses might want some support and education around caring for Hep C folks, so that was our first P. Our do was to the background research that Heidi did. The study was to complete our initial document, and that was the study and the act. And then we went through another cycle where our plan was to disseminate the document, talk to the nurses. And so right now we're within sort of that second do, study, and act phase. So I guess that's where we talk about the next steps, because we're kind of in that do, study, act phase. So we'll be soliciting feedback, Heidi solicited feedback from the nurses, but we also want to get information from our interprofessional team, which we have the pleasure of working with. We're looking to talk with the pharmacists, our physicians, our infectious disease specialists, some other Hep C treatment nurses that are in on our team, and also with our patient advisory board, which is our people who have gone through our program, our clients, and they will be able to advise us on some of this document. And then we will update the document based on their feedback and create a plan for knowledge transfer. So in terms of our lessons learned, from a preceptor perspective, as Heidi's preceptor, it was my first time working with a student on a quality improvement project, and overall it was a good experience. I think it's an important part of student clinical practice placements, if students are interested, to have opportunities where they can impact real quality improvement and real clinical change, and also the opportunity to develop things that they can publish and present on in order to be able to be part of the body of knowledge that's out there. But to consider when you're embarking on this type of project, especially if it involves stakeholder consultation, is that it's likely beyond the scope of an 8 to 12-week semester, and might be more appropriate for a consolidation project for students where they're with you for a longer period of time. At the very least, it's an important part of consideration when planning a project like this, because it's been a bit of a challenge for Heidi and I now that she's no longer placed at our site, to keep the momentum going for the project.
And from a student perspective, it can be intimidating to work on a best practice tool for experienced nurses before I have graduated from a nursing program. However, the nurses at Sherburne Health Center created a very positive environment and enabled me to feel confident to present what I had found in the research. As well, having this project to work on throughout the placement was beneficial, as it ensured that I had work to do during the downtimes of the program and gave me a sense of ownership and commitment to the program even after the placement was done. So we have just a screenshot of the best practice tool that we have created so far. The main components we included in the tool are screening, transmission information, understanding the complexities of hepatitis C testing, as well as assessment and future care, and then some resources for patient education about healthy lifestyle.
And drawing on my background from primary care, I wanted to include guidance about recommended immunizations, routine screenings, and especially the social impact of Hep C, which can be a stigmatizing illness for folks. We believe after the consultations with the nurses at Sherburne, that we may look. This is a paper resource that we were able to circulate with the nurses, but we think that perhaps like an online tool might be more helpful, easier to access, and easier to keep more up to date as things are really changing quite quickly in Hep C. But we feel after some future stakeholder consultations that we'll have more concrete ideas about what changes need to be made. So that is our overview of our project. Thank you very much.
Wonderful. Thank you so much. That was a really excellent overview of the process that you went through to develop the guidelines. I really do appreciate that.
Thank you.
And congratulations on your graduation, actually. So that's wonderful to hear as well.
Thank you.
So we do have some time for questions for Mary and Heidi. So we can wait and see if we get any questions for you specifically, and then we will open up questions to both sets of presenters as well. So I do appreciate that. So have you been now, you mentioned you've been in touch now with the Sherburne site since having completed your placement?
Yeah, so Mary and I have been emailing back and forth since I left in December to try and work further on the stakeholder consultations, and it's been a little difficult juggling the time of being a student and now starting work, but we're trying to make it work so we can continue the project.
And we're looking at other opportunities of how we can get to the next step, because I think this is a really important initiative. It is a challenge.
Mm-hmm. Well, and it's pretty amazing when you can have a student come in and really hit the ground running and contribute in such a meaningful way. So that's definitely very special, and you should be very proud of yourself.
I'm very lucky.
Yes. So that's fantastic. So I think what I will do now is just open up the question Q&A session to both sets of presenters. We did have one question come in at the tail end of the question period for the Simcoe Muskoka team. So I will read that one now, and anybody with questions for either presenter, please feel free to post that into the chat section and post to all participants. So one of the questions that we had for the Simcoe Muskoka team was 2 big reviews have since come out, and how would you recommend handling decisions based on rapid reviews in such a rapidly evolving body of literature?
I think that's a great question. This is Natalie from the Child Health Program. I think one of our challenges that come out is the rapid review process is quite an intensive process for us, and so we try to keep up to date with literature as it comes out, but again, it comes out so quickly, so sometimes we'll stumble across it accidentally in the sort of different listservs we've come to, or other people bring it to our attention. And so we sort of have cycles in terms of when we refresh or go back to things, but it doesn't happen as quickly as literature comes out. So if we find things that contradict or new or update the findings, then we would go back and start reflecting on the decisions we made and determine what steps we would make in terms of new evidence for program planning.
Perfect. Good. I think that makes a lot of sense. So we do have a couple of closing slides on our end. So I think what I'll do is just go through those slides, and then any questions that trickle in during that time, we'll make sure that we answer before we close. We do want to thank both presenters again for excellent presentations, lots of key messages, lots of takeaway messages for the audience. So I really do appreciate that. I think it was very thorough and very informative. We would like to encourage everybody to check out the EIDM Casebook online if you haven't already. Both of these stories, in addition to 7 other stories, are included in there. And we're also interested in hearing if you have a success story that you might think might be useful for others working in the field. So please feel free to email us. And if you are working on something and maybe it's not quite a success story yet, please don't hesitate to contact the NCCMT for help. We have knowledge brokers on staff, and we usually respond within about 24 business hours. We're very excited to work with you. That's kind of one of the more fun parts of our day, is actually getting to do some of the hands-on and coaching and mentoring. So we're very, very happy to take any questions or give any recommendations on anything that you might be struggling with. So please don't hesitate to get in touch with us. Your feedback is very important to us. So this was, I think I mentioned, the 3rd and final webinar for the peer-to-peer series for this year. So we are very interested in finding out what you thought of today's webinar and the other webinars in the series if you are able to attend those. So there is a very short survey. It's about 10 questions that's available at that link. And one thing that we're doing a little bit differently is that there will be a survey emailed to you about 3 months after today's date to see if you have been using EIDM in your practice. So please keep an eye out for that, and we do appreciate if you take the time to complete those surveys. And we're also very excited. So for next year, we are looking at publishing the 2nd issue of the EIDM Casebook. So the call for abstracts is now opened. It opened at the beginning of November. We will be accepting submissions until Friday, January the 12th of next year. For more information as well as the abstract template, please visit our website. There's a link on the screen as well as in the chat section. So we're very much looking forward to some more submissions this year. With such quality submissions last year and some really inspirational stories. So we're very excited to hear from the community and see how EIDM has been used in practice. We do offer a number of different webinar series from the NCCMT. These are all detailed with a description as well as the date and time of the next webinar in each series on our website. The Spotlight series features methods and tools from the registry. We ask the developer of the tool to present it, and they can give background on why the tool was developed and how, and these presentations typically feature a user story as well, so that somebody who has used the method or tool can give a first-hand account of how they used it, lessons learned, and key messages for anybody else who might be wanting to use it. And while we are the NCCMT doesn't operate within a specific topic area of public health, we do host a webinar series where we focus a little bit more closely on certain topics in public health. These webinars usually run in the spring, so we don't have any coming up until early next year. And topics in the past have included things like mental health or health equity, environmental health, and we're looking for suggestions for topics for this upcoming year as well. And then the Online Journal Club is a small group format webinar. It gives you a chance to practice your critical appraisal skills in a small group setting, so we do limit registration for this one. It's hosted by a couple of experts from the NCCMT, and it's a great way to connect with colleagues from across Canada and really around the world. We have a couple international participants usually as well, so it's a very unique opportunity to practice your skills in a very safe and accepting environment. And of course the peer-to-peer webinars, which you've attended today. So looking at the chat section, I don't see any more questions coming in. So if anybody in the audience thinks of one later, please feel free to email us. We can make sure that we get you in touch with the authors in case there are any more questions. But I think for now, we will close it out. We'll close it a little bit early, which there's nothing wrong with that. I know everybody's happy for a bit of extra time in these busy times. So I do want to thank everybody for joining us, especially our presenters, for giving such thorough and interesting presentations. I will thank everybody and then hand it back to the presenters in case you have any more comments. Thank you so much, and we hope to see you at other webinars from the NCCMT. All right, thank you so much, everybody. Take care.